All right. Well, hi, everyone. So as most of you know, I am the PI of the CTSC, which is Clinical and Translational Science Collaborative. So what we do is really bring all these wonderful institutions that you're looking at the logos of together as to collaborate more. We provide funding, services, everything they need for their research. So events like this, they're very important for us. We do record them. A lot of clinicians cannot make it today, but a lot of people listen to it after. So I want to introduce the speaker and thank you for everyone who joined. So I'm excited to introduce Dr. Rebekah Walker, who's a health services researcher and associate professor of medicine and division chief for the Division of Population Health in the Department of Medicine at Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo. Her research aims to reduce and eliminate health disparities by addressing social and structural determinants of health. She has a particular emphasis actually on addressing the influence of food insecurity, a very important problem in adults with chronic diseases. And as you know, this government, right, they're very into prevention. So food and food insecurity is really an excellent preventive strategy for chronic diseases. Rebekah recently completed a NIH-funded R01, currently has another one testing the efficacy of interventions aimed at improving health outcomes for adults with important chronic diseases like diabetes and cardiovascular disease. So Rebekah, we're excited to hear you talk, and thank you for accepting the invite.
Well, thank you very much. So I'm excited to walk through some of the work that we've been doing in this space. I want to just make sure everyone can see my slides okay.
Yes.
Okay, great. So what I'm going to do is first just give a little bit of information on the burden of food insecurity. A lot of people are aware of food insecurity, but they might not be aware of the broad-ranging burden and impact, particularly on individuals who have chronic disease. And then I'll walk through some work we've done to understand the pathways of how food insecurity influences health outcomes, some interventions we've been testing to see if we can mitigate that influence, and then move into more of the structural determinants of food insecurity and food access, and some policy interventions that could target that level of influence. So food insecurity as defined by the USDA used to be this first bullet, the limited or uncertain availability of nutritionally adequate and safe foods. But they recently updated it to be a little bit simpler as the access for all people at all times to enough food for an active, healthy life. One of the things that's very important about food insecurity and not often clear is that it is not a dichotomous type topic. So individuals are not necessarily just food secure or food insecure. There are individuals who, in this image here, would be in the very low food security. This is the group that a lot of people think of when they think of food insecurity, where individuals have to skip food. They are hungry because they do not have enough food. These are very high levels of food insecurity or very low levels of food security, depending on which phrasing you want to use. However, there are more marginal and low food security levels that do have an impact on health outcomes. So marginal food security has a lot to do with individuals who may not be able to fulfill their food needs. They might worry about doing so, and they have changed the quality or the type of the food because they are food insecure, similar with the low food security category. So, if you simply dichotomize and say anyone with any level of food insecurity, so marginal, low, or very low, um, individuals that have indicated they fit into that category anytime in the past 12 months would be 18 million US households in this past year. So, it's quite a large burden. You can see on the graph on the right that it does map to economic events. So, you can see the recession in 2007, 2008, the numbers go up quite highly. And then you can see again with COVID, the numbers increased. There are also, unfortunately, a number of disparities that are associated with food insecurity. You would imagine there are economic disparities, and that is true. However, there are also disparities by race, ethnicity. You can see over time that individuals who indicate a non-Hispanic Black or a Hispanic household lead, a head of household, would have a higher level of food insecurity compared to individuals who indicate non-Hispanic white or another race ethnicity. And there's also quite a big economic impact. So it is estimated that food insecurity it results in $77.5 billion of additional healthcare costs annually. On average, and if you think about this from an individual standpoint, individuals who are food insecure spend on average nearly 2,000 more on healthcare than individuals who are food secure. And those costs are most likely to occur in inpatient hospitalizations and prescription medicine. So the last aspect that I just wanted to touch on before I walk into the detail about chronic disease is the larger topic of food access. So food insecurity tends to be the most measured focus. However, food access, when you think about it at a community level, there are more aspects than just an individual's food insecurity status. It also has to do with awareness of food access in their neighborhood, the availability and the type of food, the accessibility of that food. If you think about transportation options to access grocery stores, for instance, would be an aspect of accessibility of food, as well as the affordability of food. So all of these come into play when considering if individuals are food insecure or not, and whether they report that food insecurity. I'll touch on that a little bit later on what we found in trying to identify individuals for interventions. So food insecurity is associated with higher prevalence of multiple chronic diseases. Individuals who are food insecure are 2 to 3 times more likely to have diabetes. They're 6 times more likely to have cardiovascular disease. And if they have diabetes, they are more likely to have worse glycemic control, which is then associated with comorbidities and complications. Food insecure adults also have a higher risk of stroke and of a 10-year cardiovascular risk outcome. You can see here that this is dose dependent. So if you think about those categories from that first image, individuals who have very low food security have the highest levels and prevalence of stroke, coronary heart disease, diabetes, arthritis, and hypertension. But there is not a simple, if you have food insecurity, you have a higher prevalence. The higher the food insecurity level, we're seeing a dose dependent response with the prevalence of these different diseases. Mortality does remain high for individuals with food insecurity, despite adjusting for factors that we would expect would explain that. And as a result, some of the evidence looking at potential pathways for how the food insecurity impacts chronic diseases suggests things like stress, the poor nutrition that's a result of reliance on affordable and calorically dense meals, and spending trade-offs that individuals need to make. If an individual, for instance, decides to purchase food but then does not purchase medication, you can imagine how that would play into their chronic disease control. So we've done a number of analyses looking at pathways of influence, and we've used a methodology called structural equation modeling to look at this. This is a statistical methodology that's based in regression. So you'll see when I pull up the structural equation model images, they'll have coefficients just like regression coefficients, but it allows for more than one independent and one dependent in every individual model. So what that does is it allows us to look at the pathways through which an effect occurs. What you need to do in order to do structural equation modeling is you need to hypothesize what your pathway would look like. So a lot of people sometimes think that you can just kind of throw everything in there and then it'll tell you what the path is, which is not actually true. What you have to do is hypothesize what you expect that pathway to be. You then test it and you see if the data supports the pathway. So the first analysis that we did looked at pathways between food insecurity and glycemic control in adults with type 2 diabetes. So you can see on the right, this is our hypothesized model. So each one of these arrows was a pathway that we hypothesized existed based on a review of the literature. So we were hypothesizing that food insecurity was impacting glycemic control through individuals' level of social support, perceived stress, and self-care. This study was done with a data set that we collected from 615 adults with type 2 diabetes. They were recruited from two different primary care clinics, one a VA and one an academic medical center. And they completed a suite of questionnaires that were then scored and put into our model. And what was very interesting is that we found that once you accounted for these different pathways, the pathway that we expected to occur, which would be through food insecurity influencing stress, stress influencing an individual's self-care, and then that self-care influencing A1C, actually did not occur. So that was not supported by the data. There were two different pathways that were supported. One was that self-care was being influenced by stress. However, glycemic control had a separate pathway that was outside of an individual's self-care behaviors. We hypothesized that this pathway was the actual food that individuals had access to and were eating. And we use this model as a way to hypothesize the intervention that we just completed that I'll go over in a moment. We also then looked specifically at this stress pathway. So in the questionnaires that we had 4 different measures of psychosocial factors. So we had depression, which was measured using the PHQ-9. We had diabetes fatalism, which is a measure of individuals' fatalism about the outcomes of their diabetes. Stress, which was a general perceived stress, had to do with an individual's stress over the past 30 days, just in their general life. And then diabetes distress had to do with distress that was related to either their diabetes care or their self-care for diabetes. We tested the relationship and the pathways for each of these different psychosocial factors with multiple self-care behaviors. And what we found that was interesting was these different psychosocial factors had differential pathways on these outcomes. So if you, for instance, were interested in impacting an individual's exercise, it might be more important to focus on depression in a food insecure population because that was the pathway we were finding. However, if you were focused on diet, stress, general stress, and diabetes distress had a stronger pathway for those. You can see that diabetes distress also had this pathway at the bottom that went direct over to A1C. And blood sugar testing and medication adherence were the strongest pathways through which food insecurity was impacting A1C via these psychosocial factors. Then finally, we did a study looking at possible mediators of the relationship between food insecurity and A1C using a national data set. So we used the NHANES data set. They have some information on body composition using DEXA scans. So we investigated the strength of multiple body composition measures. Total lean mass was the most strongly associated with both food insecurity and A1C. So we used that as our body composition measure. Similarly, we looked at BMI and waist circumference. Waist circumference was the strongest measure. And then we looked at a number of measures for healthy eating, and the overall healthy eating index was most strongly correlated. So we tested these as potential mediators in the relationship, and we found that waist circumference and healthy eating index were supported by the data set. However, body composition was not. And so what these types of studies have really done is helped us to hone our intervention development, focusing on things like weight loss, the healthy eating, and the education surrounding that, really focusing on these areas. What it also did was suggest that we did not need to focus on measuring body composition as part of our interventions, and instead could focus on these other measures that were serving as these pathways. So then to step through some of our individual level interventions that we've tested. So this is the first intervention. This is the one that I mentioned. We used the pathway analysis to hypothesize this intervention. So this was funded by NIMHD. It was a 5-year randomized control trial where we randomized 300 low-income food insecure African Americans with type 2 diabetes into one of 4 arms. So we used a factorial design for this. And interestingly enough, the reason we used that was we did some focus groups before we submitted this grant, and asked individuals in the community. We were in Milwaukee at the time. We asked individuals the types of food supplementation that would best work for them, what they thought would be most relevant for individuals with type 2 diabetes who were food insecure. The monthly food boxes that were already packaged together and an ability to use vouchers to select food were picked up as the most important. They did not find food, farmers markets as highly important. So we did not include that, even though there was some evidence testing that. That might have a lot to do with in Milwaukee, you weren't going to be able to access a farmers market all year long. So we focused on those 2 types of supplementation. And during our focus group, when we asked which individuals would prefer, one of our participants said, well, can't we have part of each of them? So we designed this study to test first if layering food supplementation on top of diabetes education would result in a greater drop in A1C compared to just diabetes education alone, which we know can result in a decreased A1C. But then secondly, we wanted to look at if the type of food supplementation mattered. So we had 3 different arms with food supplementation in them. All 4 of the arms received diabetes education that was delivered via the phone. One arm received $50 worth of food stock boxes. One arm received $50 worth of vouchers that they could purchase food from a mobile market that was essentially a moving grocery store that drove around the neighborhoods. And then the third arm received $25 worth of the prepackaged boxes and $25 worth of the vouchers. We followed individuals for 12 months, and we are in the process of publishing this. We just finished it just before we moved here to Buffalo, and we did not find a difference between the arms. So spoiler alert, that it was our finding. We did find a drop in A1C across all of our arms, but the food supplementation did not increase A1C above and beyond diabetes education. Some of the really important lessons we learned, however, during that study was, first of all, to deliver food supplementation interventions, it required a very strong partnership with the group that was providing the food, which suggested a lot of implementation considerations if this was going to be rolled out, for instance, in a healthcare system. Secondly, there was a big disconnect between how food insecurity was being measured and the individuals who were experiencing food insecurity perceived it. So we found about 6 months into the study that our program assistants came to us and said, you know, we're interviewing a number of individuals. When they talked to us during their their enrollment process and their consent process, they are talking about experiences that are food insecurity. But when they answer the USDA scale questions, which is the screener questions we were using, they do not score for food insecurity. So what we were finding was that individuals, for instance, if they were obtaining food at a food pantry, they would answer the question of whether they could obtain food regularly as yes. However, from the standpoint of whether they were food insecure, that would actually suggest that an individual was food insecure because they needed to go to a food pantry to obtain food for their family. So we changed our screening for food insecurity, and we instead used a series of questions that would indicate if an individual was likely food insecure. Some of these questions had to do with food. However, others had to do with things like if they missed or skipped a doctor's appointment because of cost, if they did not refill prescriptions because of cost. And so things that individuals are making trade-offs, and they might have purchased food, but they were making important health trade-offs. We now use this screener for all of our interventions moving forward. It's been very successful. The third thing that we found was that the stock boxes were very heavy. It made it very difficult for individuals with transportation limitations to take the stock boxes and use them, and the food that was in them was not extremely desirable. We purposely used the USDA stock boxes so that it was linked to a program that already existed in case it was successful so that we could roll it out. But this was definitely not something that was supported by the participants. The mobile markets, they did appreciate the food that was available. However, cancellations occurred relatively often, and therefore being able to access the mobile market was unpredictable, and the options did vary. One factor that does play into this is we started this study just before COVID. So you can imagine in the initial phases of COVID response, if the individual driving the mobile market was sick, the mobile market wouldn't go out. If they weren't able to put the food together, they weren't able to send it out. So there were particularly a lot of cancellations during that first year of the study. However, even beyond that, it was a relatively unpredictable process. So we talked to our study participants about additional ways that we could meet food insecurity needs and based our later studies off of this. Finally, the other thing that I wanted to mention that we learned from this study was that there was a lot of stigma surrounding food insecurity that is not often measured or considered in food access efforts that really needs to be considered. If individuals are not indicating that they're food insecure, they therefore might not be connected with the resources that they would need. So the second study that we did was funded by some American Diabetes Association funding that I had, as well as some institutional funds of my mentor at the time. And we did a 6-month RCT that was looking at financial incentives. So my primary mentor was in the process of doing an R01 looking at financial incentives in individuals with type 2 diabetes. Financial incentives had been shown to be relatively effective, just not tested at large scale for individuals with type 2 diabetes, but they had not been tested in food insecurity. Given that food insecurity is not simply a food concern, but is also a poverty concern, we structured our food incentives a little bit differently than other financial incentive studies. And we focused this on 150 food insecure adults who had poorly controlled type 2 diabetes, looking at a change in A1C at 6 months. So these were the 3 financial incentive arms that we tested. The first received a $100 unconditional payment that they could use to purchase food. The second received that same $100 financial incentive payment, but they received additional funds if they purchased healthy food, which we used if they turned in a receipt, they would then be reimbursed up to $25 a week for addition on the top of that $100. we used a very broad definition of healthy food. We didn't specify that down to detailed, and we allowed individuals to purchase more than that. We would just reimburse up to 25. And then the third arm had the monthly unconditional $100, as well as the $25 for additional purchasing of healthy food. And then they had a financial incentive if their A1C dropped at 3 months and at 6 months. We mailed diabetes education to all of our participants, and then we measured their A1C at 3 months and at 6 months. We are in the process of publishing this as well, and what we found was that all three of these incentive structures did result in a drop in A1C. We did not power this to compare between the three. However, the largest drop was this multi-component intervention. And so we used this and built out a new intervention, which is the RO1 that we're testing right now. Some of the things that we learned from this was participants really preferred health education that allowed for discussion regarding food choices. So we switched over to telephone-based education instead of mailed education in our RO1. All the incentive structures resulted in the improved outcomes, but the multi-component structures seemed to be more effective. So we used a multi-component structure. And then one of the things that was unclear was what the amount of incentive that was needed. So we held some focus groups, identified what we wanted to test, and we were funded for an RO1 that is now ongoing. Looking at testing a financial incentive structured intervention that is aimed at reducing cardiovascular risk outcomes. So we're using the 10-year cardiovascular risk score as the primary outcome, and we're aiming to decrease that in African Americans who are food insecure and have any risk of cardiovascular risk at the start of the study. We will provide the individuals in the intervention will receive a monthly income supplementation as well as a weekly structured incentive for the purchase of healthy food. And then everyone in the study receives evidence-based CVD risk reduction education that's delivered over the telephone. We'll be following them for 12 months, and we just hit our 25% mark, so we're on the way on this one. So then stepping back from the individual level interventions, I want to talk a little bit about structural determinants of health. So one of the things that we have found is that a lot of focus has been placed on individual food insecurity. So this is a model that was developed by the World Health Organization to explain how social determinants of health impact health outcomes as well as equity in health outcomes. You can see this one box that is closest to health outcomes is the intermediary determinants, and food insecurity would fit into this area. So it would be in the material circumstances, and it has the closest relationship with health. However, if you back out to the structural factors that occur before this, what you see is there are socioeconomic and political contexts that create the environment in which an individual is food insecure. And this is something that we've started to want to investigate more, to identify if there are interventions that can be done at this level, as opposed to only focusing on individual level interventions. So to give you some examples of what these types of policy interventions would be, so for governance, this would be things like policies on taxation, the degree to which the government subsidizes healthcare or education. Macroeconomic policies would include things like labor policies, minimum wage, or unemployment. Social policies would be things like Medicare, Medicaid, housing policies, or SNAP. Public policies would include Affordable Care Act, Clean Air Act, education policies, immigration policies. And then there are additionally cultural and societal values, things like whether the nation or the state or the city or the region, that we have a lot of culture that differs across the US, consider healthcare as a right versus a privilege, individual responsibility versus collective action. These result in different policies being put in place, which creates a different environment. The primary mechanism that has been found in the literature for how these socioeconomic and political contexts influence social determinants is through poverty. And that is very relevant to food insecurity because food insecurity, while it has primarily been focused on as a food access issue, it is really a poverty concern. So, one of the other aspects when thinking about these structural factors, however, is structural inequalities. So, when we talk about individual level health disparities, we're looking at differences in populations. When we're talking about structural inequalities, these have been found across societies, and they are really based in access to power and resources that then result in socioeconomic stratification. These types addressing structural inequalities results in very different types of interventions and strategic targets that need to be addressed. So again, understanding these causal pathways is a concern. And then within the context of the United States, structural racism is a subset of these structural inequalities. So structural racism, as defined by one of the Lancet did a systematic review that looked at the impact of structural racism on health. They define structural racism as the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems. Essentially, if you think about the broader idea of structural inequalities, when those inequalities are based on race, they are now structural racism. Evidence does show that structural racism has been associated with a number of poor health outcomes, including lower life expectancy, worse cardiovascular health, higher prevalence of chronic disease, worse self-care behaviors, and more years of life lost due to diabetes. And there's two concepts that are important to understand when thinking about these structural factors. So Richard Rothstein in The Color of Law identified these. De facto would be something that is true in fact, but is not officially sanctioned. Whereas de jure would be something that is sanctioned by law and public policy. The reason that the separation of these two and the identification of these two is important is because if something is put into place through a law or a public policy, it has a much broader ability to reinforce this, what would normally be an individual prejudice or a personal preference. So the use of judicial decisions, policies, and laws will take something and put it into place across a society. Historic redlining tends to be one of the most often measured ways of thinking about this structural racism. Historic redlining is not the singular measure of structural racism. It is just a very common measure because it was put in place through laws. It was afterwards indicated as being illegal and removed. However, it is consistently being found that individuals who live in neighborhoods that were historically redlined still have health impacts from those historic activities. So if you're not familiar with this, redlining is the previously legal practice of systematically denying credit access and insurance to residents of specific neighborhoods, and those specific neighborhoods were often based on the race ethnicity of the individuals living in the neighborhoods. There were grades that were given to neighborhoods, and then based on those grades, the individuals living in the neighborhoods or the companies that were developing those neighborhoods could or could not get mortgages or funding in order to develop them. And as a result, what it did was it took a decision about the ability of individuals in a specific neighborhood, put it into law, and then resulted in these long-term impacts that we have seen. So this is a map of Cleveland, and you can see these different colors that are laid out based on the redlining map. So the reason that redlining is termed the way that it is because of these red blocks. The red blocks were considered the hazardous neighborhoods. And in most cities across the entire United States that were redlined, these neighborhoods are still the neighborhoods that have the lowest socioeconomic status, the lowest number of resources, the highest level of chronic disease and poor health outcomes. So you can see the four colors were laid out. Green was considered the best neighborhoods, B was considered still desirable and colored blue, C was considered declining and colored yellow, and D was considered hazardous and colored red. This process was formalized in 1934. It was later prohibited in 1968. However, the law made it illegal to create these maps and to base a mortgage on it. But it has been found that individuals are still doing this. They are just not doing it under these particular maps. This is an analysis that we did. The most important aspect of this is really looking at these graphs on the right-hand side. You can see if we take these colors and we assign 1 to the best neighborhoods, the green neighborhoods, 4 to the red line neighborhoods, you can see that deaths and years of life lost increase as you move from the best neighborhoods up to the red line neighborhoods, and that this change does not change from looking at outcomes in 1990 to 2014. So this is a long-standing impact that has been seen across diabetes, CVD, childhood obesity, increased preterm birth in redlined neighborhoods, late-stage cancer diagnoses, infant mortality rates are higher, there are worse post-operative outcomes, and there is increased maternal mortality. So we've done some investigation into the relationship between historically redlined neighborhoods and food access. And so by combining census tract level data, we looked at this relationship with a few different measures. In this first study that we did, we used the USDA's Food Access Research Atlas data, and we identified food insecurity with 3 different measures that they provide in that data set. First was the share of the census tract that is considered low income and live beyond a half mile from the closest supermarket. The second would be the share of the housing units that are without a vehicle and are beyond a half mile from a supermarket. And then the third is simply that measure of the supermarket. What we wanted to do by using these 3 measures was to assess if it was just distance to a supermarket, and then the intervention would really be focusing on increasing access to supermarkets, or if it also had to do with transportation or income. So we had 8,996 U.S. census tracts in this study. They covered 213 counties and 37 states in the U.S. And what we found was that across the board, the measures were associated with the red line neighborhood. So if you were if you were living in a neighborhood that had been graded as hazardous, you had a higher likelihood of having low food access. What was interesting was that this was particularly strong for individuals who had low access and low income. And as a result, what this really suggests is that it is not just a matter of putting more supermarkets in neighborhoods, but it has to do with addressing poverty within the neighborhoods as well as increasing access to food. We did a second pathway that looked at food access as a pathway between redlining and chronic disease. So we again used census tract data. This had over 11,000 US census tracts. And we used the same measure for historic redlining. However, for food access, we used a different measure. This is the Modified Retail Food Environment Index. It's an index that was developed by the CDC, and it was calculated for each census tract based on the food outlets that were available within the census tract. So higher index scores indicated better food access, and then lower scores indicated either a high level of what was considered unhealthy food retailers compared to healthy retailers, or a lack of healthy food retailers in that census tract. And we looked at the pathway of food access across 4 different chronic diseases: diabetes, high blood pressure, coronary heart disease, and obesity. We found that all 4, the food access was a significant pathway. And you can see that there were differences in strengths of these pathways, but that food access was significant in the relationship between historic redlining and chronic disease at a neighborhood level. And then finally, most recently, we've done an analysis that looked at structural drivers of food access. So is that, again, getting at this idea of where should we target? So there was a recent paper that was published and data was provided with it by Dyer in Health Affairs that they created a structural racism effect index. What they did with this index was at a census level, they created scores for all of these different measures that are considered structural measures within neighborhoods. So the built environment had measures of internet access, mobile homes, building vacancy rates. The criminal justice measure had things like pretrial jail rate by county, total jail rate by county. There was measures of education, of housing, of social cohesion, transportation, wealth, and then income and poverty. All of these are measured at the neighborhood level. And they are turned into an index so that we could look at potential drivers and the strength of those drivers. So what you can see is that we found something that we did not expect, actually. Historic redlining was associated with all of these different factors. However, built environment, criminal justice, education, housing, and social cohesion were the pathways through which historic redlining was influencing food access, as opposed to transportation, wealth, and income, which we would have expected. What this then suggests is that the types of interventions that need to be built would be very different than just focusing on income and wealth or transportation to food areas. And instead, these would be interventions that would change the fabric of a neighborhood and the overarching opportunities that are available in those neighborhoods. This was just accepted in obesity, so will be published soon. So finally, the last thing I wanted to hit on is, given all of this information, where would policy interventions target? So given that food insecurity is a multifactorial issue, there is still a need to identify ways to improve access to healthy food at the community level. There have been some studies into things like mobile food vans, meal delivery programs. However, a lot of them have not included health outcomes. They have looked more broadly at food insecurity and if they could impact that as the outcome. So evaluating these programs and testing if they change outcomes at the health level would be important, as well as investigation into policy options for financing programs. Additionally, at the food environment level, using incentives like the Healthy Food Financing Incentive for new tax markets is a particular way to increase retail outlets. Removing zoning barriers or providing tax incentives would be a policy intervention that could change the way that food is accessed in an environment. And then doing things like changing the way that approvals or reviews are handled for placements of stores like grocery stores. As I noted a few times, food insecurity is not just a matter of food, so addressing underlying poverty is very important. We have been, in my research team, we've been doing a lot of work around the space of monetary approaches, and if we can use these monetary approaches to change health outcomes for individuals who are food insecure. There are a number of structures for how these approaches can be organized. So financial incentives are really based on incentivizing particular behaviors, whereas income supplementation, cash transfers, and universal basic income are more of a base amount that is given to individuals. Cash transfers can be conditional or unconditional. One of my team members is looking at if there is a difference in the conditionality of cash transfers and the impact that that has on health outcomes. And we've done a lot of work in focus groups and talking to participants of prior studies or individuals who might be interested in new studies to identify the range of costs that they would consider to be able to supplement certain income levels. There's also macroeconomic policies that could be considered. So one of the studies that we did that was just published was looking at unemployment as a potential way to use a macroeconomic policy and impact food insecurity. So government programs obviously have been designed to address food insecurity. However, other policies, when investigated, sometimes show that they have impacted food insecurity levels. So Medicaid expansion in 2014 was associated with a 2.2% decline in rates of very low food security. Expansion of the child tax credit as part of COVID-19 response was shown to lower the odds of food insecurity, specifically in families that reported very low food security. And then federal supplementation as part of the COVID-19 response also showed similar reductions in food insecurity, particularly among individuals who had lost employment. So we worked with an economist on this study, and there are two potential pathways for how a minimum wage change could impact food insecurity. And this is why it's important to do these analyses as opposed to assuming that a legislation could have an impact on outcomes. So one possibility would be what I naturally thought of, which was that increasing minimum wage would increase individuals' earnings, and then it would be able to reduce food insecurity. However, using economic theory, it is important to understand that there is a potential opposite possibility, which is that increasing the minimum wage would increase labor costs. That would then lead to decreased employment or business closure, which would lead to increased unemployment and increased food insecurity. So these were the two potential options. And so we used census level data, the annual CPS food security supplement to obtain two different indicators of food security. One was anyone who had indicated food insecurity, and the second was the group that indicated just very low food security, individuals who were skipping meals and hungry. We looked at state level minimum wage data from the Washington Center for Equitable Growth and inflated that to 2019 dollars. And then we accounted for different effects that would be different by county level. And this just gives you an overview of what minimum wage looked like over time and what food insecurity levels looked like over time. As you can see, we put in the marks for the 2008 financial crisis and ACA rollout just to give some time points in there. And so what we found was that $1 increase in minimum wage was not associated with a change in the low food security prevalence. However, it was significantly associated with lower prevalence of very low food security. So it did have a relationship with individuals who had very high levels of food insecurity. We also looked at if there would be differences by race, which is very important if you are interested in lowering those gaps that we see in food insecurity. If certain policy levers can change the gap, that would be a way to impact that. We did not see major differences in racial ethnic groups. And so as a result, the findings of the study indicated that minimum wage legislation may help reduce very low food security, but it would not reduce existing disparities gaps. So these are the types of studies that are really needed to identify potential policy levers and then look into how those could possibly play out. The last thing that I'll mention is economic empowerment is also an important potential policy intervention that could impact food insecurity. Things like regional adjusted livable wage, increasing new home ownership, tax incentives to create employment opportunities. And so all of these would be very different types of intervention. So in conclusion, we're finding that food insecurity is not only a key driver of health outcomes, but there are multifactorial pathways on how that impacts particularly chronic disease, and that solutions are really needed to address food access while also addressing that underlying driver of poverty. And when looking at a holistic approach that takes into account the structural drivers of food insecurity, it is really necessary to look at some different policy changes. So I'll stop there and take any questions. I saw that there were some comments coming in. I just need to see if I can find them.
Yeah, I'll do that for you, Rebekah.
Okay, thank you.
First, thank you for a great talk. And I love research that lead to changes in policy, make people's life better. So very fascinating work. So Mary Dolansky asked, how do you control for the relational components of the intervention? I mean, as you know, you change one thing, there are a lot of things that are correlated.
Yes. So what we have done is we've been more often what we've been doing is these multiple arm interventions where you can add different aspects as opposed to just you do have an intervention and you do not have an intervention. That's one way to look at it because then you can compare at essentially the different aspects of an intervention and if there's change. The other way we have started looking at this is actually doing path analyses after the fact. And so once we have the results of the intervention to see if we can identify the pathway that the intervention influences. What I would say that our biggest takeaway from this, however, is that there is not a single pathway that this is occurring through. They are very interrelated. It is not a silver bullet, as it were, that you could just kind of target this single area. And even in our education sessions, covering multiple self-care behaviors or multiple cardiovascular risks is absolutely necessary. So we haven't found that you can really kind of hone into one thing, get that aspect changed and see a result. It really does require a multi-component intervention that is theoretically based on both the factor you're trying to change in our case, food insecurity, but then also that primary outcome.
Perfect. And I'm going to ask you something related to that. It's my mechanistic pathways interest always. There are a lot of studies showing that food insecurity affect inflammation, which obviously affect diabetes and cardiovascular. Same thing, that it can affect the gut microbiome.
Yes.
In a bad way, right? To increase inflammation further, as well as mitochondrial toxicity and oxidative stress. So all of these could play a role. Do you get like blood and stools at least in your studies? Because that'd be easy enough to measure.
Yeah, no, that's it's a really important point. We do not in our studies because the way that we are rolling out our studies are in a population level. So we do primarily community-based recruitment. However, we have a few colleagues here at UB who are doing this. They're bringing individuals in and they are capturing blood work as well as stools so that they can look at that because it's very interesting, and what they're really trying to understand is if there are essentially profiles of individuals that you could identify and then target interventions for.
Yeah, perfect. I know Sherry Boland had to leave, but I know Sherry should be listening to you tomorrow when we release the recording. So she asked a couple things about the incentive. The first intervention you showed, why $50 a month only? And then a related question, how did you decide about the financial incentive?
Yeah, no, it's a great question. So we made all of our decisions based on discussions with participants, potential participants and focus groups. So what we generally have done on all of our interventions, and we did both before the food supplementation study and the food incentive study, is we met with a group of individuals. We described the intervention to them. We asked them their thoughts on the intervention, what we weren't accounting for, what they thought needed to be added. And then when it had to do with money, we asked them, what do you think would be a reasonable amount by week, by month? And then for the incentives, what would be a reasonable control group? Because that was also a concern when we did CVD Fit. Our control group does not receive any incentives. across the board, for the most part, we have found that if you are providing some kind of education that the individuals consider worthwhile and valuable, they have not been as concerned that they would not receive intervention, the incentives, and they are willing to be randomized. And we have not seen a differential dropout. We were kind of expecting that we might, and so we did look for it. But I do think that had we just done mailed education, it's highly possible we would have seen that differential dropout. So the individuals in our control groups appear to be putting a lot of value on that time that they can spend with health educators to really talk through their behavior change, and they see that as valuable as the incentives.
Perfect. Nancy's asking, any thoughts about differences in insecurity levels and outcome based on urban versus non-urban areas?
So we've done all of our interventions in primarily urban areas. So we have not done a lot of work in rural areas. That is not to say that it does not need to be done. There's actually a lot of food insecurity in rural regions. The interventions might need to be different. The considerations might need to be different. And so I don't have a lot of information on it just because what we've primarily been working on is in an urban space. And so for the populations that we've spoken with and delivered interventions to, things like transportation has been a major concern. The ability to access specific types of food outlets. So for instance, our incentive study, we load funds onto a general card, like literally a Visa card, that they can use anywhere, because we originally were going to use a grocery store, but then they could only go to that singular grocery store. What that puts into play, however, is you cannot control how individuals will spend the funds. So one of my colleagues, the one that's doing the work on the cash transfers, she actually put a process into hers that after the study was over, they assessed from the bank cards, what the costs were going to. They over 85% of them went to food, utility costs, medication costs, and other healthcare related costs. So they really were going to what you were expecting it to go to, and what you were hoping it to go to, without controlling the usage.
Perfect. So Sarah Ronis asked, she's very intrigued by participant interest in having conversation about food choice. Are you learning anything about what type of questions or conversations are occurring with your interventions?
Yes, that has been very interesting, because our health educators have really needed to be very open to discussing changes over time with our participants. So for instance, we found that we started covering with our incentives diet soda, because it helped individuals move from full sugar soda to diet soda to non-diet drinks. And so by helping them move along that pathway, or moving from a complete regular grain to a whole grain to a different type of grain, and helping them over the course of the intervention make that change, has actually been something that I don't know that I would have thought of as part of what's needed. Really, what we found is the problem solving with our health educators has been extremely important, because individuals' choices, their diet choices, their diet preferences, what they would like to try or not like to try, it's very hard to do that in a standardized fashion that does not have some kind of discussion and problem solving. So that is one reason that we've been relatively open with our coverage of healthy food, to really let people make that progress over time.
Perfect. Mackenzie, can you please take over? I have to go to another meeting. I know there are two other questions. Oh, Sherry, you can go ahead and ask it. How about that?
Mine are just more follow-ups. Thank you, Grace, for asking my other ones. I had to jump off and then go back on. We've had a lot of, this is an area ripe for a lot of research, and maybe I should reach out to you, Rebekah, to talk more. We've done a lot of produce prescription programs here in the region. And also we have a food as medicine clinic, so we've done some work with that as well. And one of the things we've bantered a little bit on is like how much to give people. So I was not thinking so much about the incentive for participation piece, but more like $50 a month for food seems small, or even
Yeah.
the equivalent of that. And we've also done some work looking at like what's the amount per household. Obviously, a very large household would have different needs than a very small household, and we're often giving food for the participant and their families because it's a lot of people with kids, etc. So I don't know if you have run into any research. My understanding is we still don't really know, but I wondered if part
Yeah.
of the reason you didn't see an effect was that the amount was too low in the beginning with the box versus the, like you had that, I think it was the one with the $50 a month,
Yeah.
25, you know. So I just was wondering if that food was too little and if you've thought more about that in the interventions you've done.
Yeah, so we definitely, so part of what we were also trying to do with the amounts was to match out to what individuals can get with SNAP or what they can get with other programs and the amounts that they cover on that. And we definitely are finding that the amounts individuals can get covered for on existing programs is not sufficient. The amounts that we are covering, they are helping to supplement. And one of the things we purposely did do was that being on any other food supplementation program was not an exclusion criteria. So this was specifically to supplement food, and we indicated as such. And I think that that's an important aspect, that if what you're looking to do is to provide sufficient amounts of food, it needs to be quite a bit larger. And that I haven't done any of the medically tailored meal
Mhm.
studies, but I have some colleagues who have, and their biggest concern has always been the cost, because they can cover essentially one or two meals, which is not really changing an individual's diet.
Yeah. Well, thank you. I just thought I'd ask that out loud, but this is
Yeah,
great work. I feel like we should just chat separately.
yeah, absolutely.
Okay, I know we are 2 minutes over. Dr. Walker, if you're able to stay on just to answer
Yeah.
this last question, and I'll pop up a conclusion slide, and if others have to go, they can. But in the chat, Shannon had asked, can you speak to the sustainability of health behaviors or food security post-intervention during a follow-up period?
Yeah, so we did not do any kind of sustainability aspects on the food supplementation. However, the financial incentive study that I mentioned that my mentor did, that was with 450 adults, and they stopped the incentives at 12 months and followed them for 18 months. And what was interesting was the incentive arm, there was no significant difference between the incentive arm and the control, which was a home telemonitoring control. However, at 18 months, the incentive arm was holding and the home telemonitoring arm was increasing again. So they did not have access to the home telemonitoring. Financial incentives didn't have access to the incentives, but it seemed as though the incentive group had shifted. The idea behind incentives is that you're helping people shift from an extrinsic to an intrinsic, and it was suggesting that was occurring actually in that incentive group. So it will be interesting to see if that holds in a food insecurity group, because again, you're not just dealing with the incentive, you're dealing with poverty. So that base amount of income, I don't know that if you remove that, you will see the sustained effect. You can probably remove the incentives, but there might need to be an aspect of that continues.
Great. Well, thank you so much for joining us today. I am not seeing any other questions in the chat. Be on the lookout for an email from the CTSC of how to claim CME credit, and enjoy the rest of your day. And thank you so much, Dr. Walker.
Thank you.